Al-Qasmi Women and Children Hospital, will be the moderator of this evening. And Dr. Manjulla, please.
Good evening, everybody. Dr. Muna, thank you very much for this warm welcome. I also thank Vitabiotics for inviting all of us to this webinar and organizing this great webinar for this evening. Now I invite Dr. Muna Kalfan, the head of the Department of Obs-Gyn and Fetal Medicine at Al-Qasmi Women and Children Hospital, to give this lecture on cardiac weaving of fetal cardiac weaving. She is head of the department since 2015 at Al-Qasmi Women and Children Hospital, and she is also the head of termination committee in Mohab, chief examiner in Mohab as well. She is Arab board in Obs-Gyn with master in ultrasound, obstetrics and gynecology from University of Zagreb Medical School, Croatia. She has specialized postgraduate training in advanced obstetric ultrasound in 2008 from Ian Donald University of Medical Ultrasound from Doha, Qatar. She is an adjunct clinical professor in Sharjah Medical University and also instructor in postgraduate diploma in ultrasound technology application. She is also a CTG instructor and also instructor in EHS as well. Dr. Muna, the floor is yours.
Thank you, Dr. Manjulla, for the nice presentation. I will start, inshallah, with a topic which I like to repeat it. I like to stress on it, not because I like this topic, just I have a lot of topic which I really like it in fetal medicine. But in the last few months, majority of the medical litigation which I come across in the medical liability are about missing diagnosis of congenital heart disease. Yes, we know that the missing the diagnosis of congenital heart disease can occur, and the percentage of detection hardly in a good center, 50–60%, but the patient expectation is changing. Patient expecting that they are with you, you are doing anomaly, you need to detect at least the major congenital anomaly. So why I'm stressing on 4-chamber view, you cannot say that you have done a basic fetal anatomy if you cannot do fetal 4-chamber view heart properly. And minimum you need to add to it outflow. For the talk of today, we are going to stress only in 4-chamber. I will just give you one slide about other transfers measurement or a few which you need to obtain. Why we need to detect congenital heart disease? Prenatal identification and management of fetal cardiac abnormality are important because congenital anomalies are leading cause of infant death, and congenital heart disease is the leading cause of infant death due to congenital anomalies. So you can find that it is extremely important things. Congenital heart disease is a leading cause of infant mortality with an estimated fetal death or incidence of about 4 to 13 per 1,000 live births. Between 1950 and 1994, 42% of infant deaths reported to WHO were attributable to cardiac defect. Structural cardiac anomaly are considered among the abnormality most frequently missed by prenatal ultrasonography. And this is correct. This is the situation worldwide. But we are looking for a better care. Our patient expectation becoming day after day increased. So when you detect it, what will do? You can argue that law of UAE will not allow termination. We will discuss the benefit. But before that, we need to discuss how can I improve my detection rate. First, prenatal detection rate vary, as we said, worldwide. It depends on examiner experience. So you need to improve your experience in doing that. Maternal habitus, abdominal scar, all these are interfering with the clarity of the image. Transducer frequency, gestational age when you are seeing the patient, amniotic fluid volume, and fetal position. We are going to discuss this while we are going through the lecture. And the most important thing, we need to have continuous feedback based on training. Basic training of healthcare professional is particularly important to improve the effectiveness and screening program. If you are not trained, if you are not updating yourself, if you are not trying to attend frequently some courses which will help you to improve your skill, I'm sorry, you cannot improve yourself and you cannot serve your patient properly. The cardiac screening examination of the fetus is designed to maximize the detection of heart anomaly during second trimester. This helps you to identify fetuses at risk for genetic syndrome also, and provide useful information for patient counseling, obstetric management, and multidisciplinary care. Suspected heart anomaly will require more comprehensive evaluation using detailed fetal echocardiography. So if you follow the checklist for four-chamber view, and we are going to discuss what we mean by this checklist. If you follow it, you will be able at least to know when you should really ask for detailed fetal echocardiography. And you can refer her for fetal medicine people at that time for proper evaluation. So why we need to do it? As we said, one of the doctors during the investigation argued, she cannot terminate, we are in UAE. Yes, that's correct. As per law, majority of the treatable cases, not a major anomaly, not lethal, we cannot terminate as per law. But if you have diagnosed the case, they at least obtain prognostic information prior to birth. Learn about treatment options for their child before and after birth. Make decisions concerning the management approach that's best for their family. Plan for a specific need where they are going to give birth. Route of delivery, is it safe to go for vaginal? Yes, no. Who is the pediatrician who will care about the baby? Who will be the obstetric provider to care for this baby and carry on regular assessment? And is it only for palliative care? So we need to discuss all these. So as we said, patient expectation is high, and it is really important if they know what is going on. So before you start, just check your transducer. You need to use the highest possible transducer frequency, highest frame rate. It needs to be more than 50 hertz, and use presetting. If you have a presetting for first trimester cardiac, second trimester cardiac, that's make your life easy. If I don't have the setting, I need to maximize the setting of my machine to be able to do proper assessment of the heart. And that's by using highest possible transducer and reducing the frame rate to increase the frame rate by reducing the width of the angle. Some people, you see them, they are scanning while the image is really wide and the heart is small, and they are telling they are seeing. I'm sorry, you are imagining, so you can miss a lot of things. General consideration, detection rate of congenital heart disease can be optimized by thorough screening examination of the heart, recognizing that four-chamber view is much more than simple count of cardiac chamber. Why you put it in red? I put it in red because this is the answer I had received several times. You wrote that the four-chamber view was normal. Yes, Doctora, I count the four-chamber. I'm sorry, it is not only counting four-chamber, it is part of the checklist, but it is not only counting that there is four-chamber. Understanding some lesions are not discovered until later in pregnancy. So there is limitation when I do anomaly scan at 18 to 22 weeks. Detection of congenital heart disease will help. So be aware that a specific type of abnormality, example, Transposition of great artery or aortic coarctation, which is extremely difficult to diagnose, aortic coarctation, may not be evident from four-chamber plane alone. Complementing four-chamber view without flow tract is therefore an important step to improve your detection rate. Okay, when we should screen. Cardiac screening examination is performed optimally between 18 to 23 weeks of menstrual age. After 30 weeks, it is difficult because the amount of liquor won't help you for better visualization of the heart. And the second thing, shadow from the ribs will be more, so it won't be that easy. Okay, I agree. In expert hand, and in some thin patient, chest anterior, even at 34, 36, we can do examination of the heart. Full examination in some cases we could do. Some anomaly may be identified during late first and early second trimester of pregnancy, especially with increased knuckle translucency or high-risk group. High-risk group, either the mother herself is a case of congenital heart disease, either she had other children before who have congenital heart disease, any family history which will increase it. So you need to think if this is high-risk group. High-risk group, it is better that the first trimester screening done first at 13 weeks and done by a fetal medicine, because they can detect at least if there is major structural anomaly. Why we are telling 13 week plus, see the difference. This is at a 12 week. We can see the right ventricle and the left ventricle. It's the same at 13 week, but you can see it more clear. And if you move it to 14 week means 13 weeks, 6 days. Still, the crown rump length will be within the accepted measurement for knuckle translucency. So the baby won't be more than 85 mm. That means I can do knuckle translucency. I can do other parameter which we are looking, which is not in our objective for today. And you can do the heart. So heart examination can be done at 13 week, which is really helpful, especially if the patient accepts transvaginal ultrasound. This is at 13 week, 2 days. You can see VSD diagnosed. It is mile-aligned VSD with overriding of the aorta. Here, this is normal view of the ductal view, or what we call three-vessel tracheal view. So it is clear. This is at 13 week. Okay. Today, actually, I'm concentrating more on the normal time for screening, which is 18 to 22. When you start the cardiac examination start in the abdomen. First, we need to assess fetal situs. So we need to decide about laterality. Which part is up, left or right, okay? So it is not stomach. This is stomach, that means this is left. No, this is left, and I can see the stomach in the left. So first you need to decide on laterality. Where is right, where is left? Situs and general aspect, fetal laterality identify, as I said, right and left. Stomach and heart need to be on the left, but not if I see them on the left, that means this is left. Heart occupy a third of thoracic area. This is part of our checklist. Majority of heart in left chest, which we call it levocardia. Cardiac access point to the left by 45 plus or minus 20 degrees. 4 chamber present, regular cardiac rhythm, no pericardial effusion. Okay, this is what we say situs. If I show you this image, if I enter the room and my doctor scanning this, first question I will ask her, is this baby in a breech? If she say no, I will tell her either this is situs inversus or your probe orientation is wrong, so check it. So you get it. We need to, I know that here it is written, left is up. So if left is up, this baby in a breech. Okay? So this is what we are looking for chamber. Yes, just now you said, no, it is not only for counting. Yes, it is not only for counting with special criteria. So if you have situs abnormality, we should suspect it if fetal heart and or stomach are not found on the left side. And it can be situs inversus or situs ambiguous, which is a serious thing. Having situs ambiguous, or what we call it isomerism or heterotaxia or polysplenia, asplenia, whatever you will call it, it is a major congenital heart disease. Then you need to look to the axis. We said that the axis need to be to the left 45 degree plus or minus 20. Abnormal axis increase the risk of cardiac malformation, especially involving the outflow tract. So now I didn't do outflow, but I found abnormal cardiac axis. What I will do, either I'm able to diagnose, so I will carry on, or this is an indication to refer. This is how we do it. We draw a line from the sternum to the spine. So I divide the chest into two. Then I go through the interventricular septum. And this way, I'm getting the angle here. And this is the angle which we measure. Okay? Abnormal displacement of the heart. Sometimes there is mediastinal shift to the left, to the right. What might cause it? It could be something not related to the heart directly. It could be diaphragmatic hernia, cystic pulmonary airway malformation of the lung, CPAM, or what we use it, the old term of CCAM. Secondary to left lung hypoplasia or agenesis. That's why the heart is going more to the left or going more to the right. A shift of axis to the left may occur with fetal gastroschisis and omphalocele, because, you know, the abdominal wall defect will pull part of it. So there will be a dysmorphic feature of the mediastinal shift, and usually it will be to the left. Okay, then we need to go to the size of the heart. All these are simple things. But if you are just starting doing anomaly scan or at least basic fetal anomaly, please start with these. You need to do it regularly in each patient. Look to the situs, and this is a must. Then decide on the axis. Then look to the size of the heart, which we call it cardiothoracic ratio, and the heart should be no larger than 1/3 of the area of the chest. Cardiothoracic ratio or circumference area throughout pregnancy is 0.25 to 0.35. It should not exceed that. And how we measure it? We take a circle around the heart and another circle internal wall of the chest. And as we agree, it need to be less than 1/3, and you need to get the ratio. How we look to the four-chamber view, we can see it in 3 planes. Apical plane, which is the best for visualization. Cardiac apex is directed toward the transducer, but in this view, the interventricular septum aligned with the insonating beam. So it will be parallel. The interventricular septum parallel to the insonating beam, the transducer beam which was sent. And that can increase the rate of false positive ventricular septal defect. So what we will do, we need to try to get the transverse view, where the interventricular septum is 90 angle with insonating beam, and that will give you sure diagnosis of VSD if it is present, but you will not have a false positive. And there is a basal view where the base of the heart will be up. We are going to see it in picture. This is the apical view, and this is the best view to diagnose overriding of aorta. When you move to the outflow, it is a best view to see the offset and I'm going to explain quickly what is offset. Sorry, the time passing quickly. And this is the transverse view, which we said the beam will be coming 90 degrees to the interventricular septum. And this is the best view to diagnose interventricular septal defect. This view, the transverse view. Okay, again, this is transverse view. If you go down, this is apical view. Apical view is not a good view which will help us in diagnosis, especially if the woman is obese, clarity will be jeopardized. So we write that we see it in apical view. When we are looking to the atrial chamber, we need to have two atria. They are equal in size. Foramen ovale flap in left atrium, atrial septum primum present near to the cracks, and secundum close to the base. Pulmonary vein entering left atrium. Ventricular chamber need to be again two ventricle, approximately equal in size. No ventricular wall hypertrophy. Moderator band at right ventricular apex. Ventricular septal intact. Apex to cracks. Okay, this is right ventricle, left ventricle, they are almost equal. There is here in the apex of right ventricle, moderator band, which is a thickened area. You can see what we are telling offset, which is, this is mitral valve, and this is tricuspid valve. Tricuspid valve, more apical than mitral. It is what? Slightly more apical. Slightly more apical. Then we will look to pulmonary vein. This is left atrium where there is two pulmonary vein. There is septum primum clearly seen. This is right atrium. And this is spine, and we should have only one vessel behind the left atrium, which is aorta. This is how we look for inflow. If you see the interventricular septum in this view, it is not transverse, but I cannot see any defect. That means it is intact. But if I see defect, I need to get the transverse view to make sure, yes, it is present or no. It is not just false positive or artifact. The ventricular septum should be examined carefully for cardiac wall defect from apex to cracks, as we agree. Septal defect may be difficult to detect. The septum is best seen where? In transverse, because angle of inclination will be perpendicular to it. When ultrasound beam is directly parallel to ventricular wall, this will need to suspect falsely that there is a ventricular septal defect. Small septal defect, less than 2 mm, can be very difficult to confirm if ultrasound imaging system fails to provide you a sufficient degree of lateral resolution, mean more clarity. Lateral resolution that we detect each near object as 2, not as 1. So depend also on your ultrasound machine. This is intact interventricular septum from apex to crux. From apex to crux. It is intact. Again, from apex to crux, it is intact. Then we need to look to normal heart rate, contractility, and rhythm. The normal heart rate range from, as we know, 120 to 160. Mild bradycardia is observed transiently in normal second trimester fetuses. You will see that baby bradycardic, baby stop, even heart stop pulsating, that's normal. If it go back quickly. Fixed bradycardia, especially if remain below 110, possible heart block. Okay, so this is a heart with normal contractility. This is the right, which is more close to the anterior chest wall. This is left ventricle. This is left atrium, right atrium. Foramen oval, we need to see it opening on the left atrium. There is only one vessel behind it, which is aorta. So if you are telling for chamber view normal, you need to look to all these checklists, and then you can say simply that for chamber is normal. We know طبعا repeated heart deceleration in third trimester could be due to hypoxia. M-mode method and atrioventricular, I'll pass it because it is not for today, but this is what we get in M-mode. If you go from right atrium, septum, and then left ventricle. So this is atrium, ventricle, and each atrial contraction need to be followed by ventricular contraction. Otherwise, it is atrial fibrillation, it is flutter, whatever the abnormality. Color flow mapping help us to detect or to confirm that there is pulmonary vein. And why we need color flow? Because it reflects variation in left atrium pressure. Systolic peak slightly higher than diastolic with a small atrial reversal. This is for pulmonary vein. You can, if you are in doubt, put color and then put power Doppler and look to the wave. This is a little bit advanced, but if you are in doubt and you are experienced, you can do that. Standard cardiac evaluation for chamber and ventricular outflow tract. If you add outflow, you increase your detection rate of something like conotruncal anomaly, such as tetralogy of Fallot, transposition of great artery, double outlet right ventricle, and the truncus arteriosus. So how we included? This is, which is upper to the right, is the for chamber view only. Where we start from abdomen, as we agreed. Stomach, descending aorta, inferior vena cava. Stomach to the left, aorta more toward the left, inferior vena cava to the right. If there is anything in the arrangement of the vessel, that's again, let you think about isomerism. There is something of laterality. And then this is how you go more kephalad. So you go toward the head and you will see the left outflow, right outflow, then you will reach to 3 vessel view and V-sign. What we might not detect at 18 to 22 weeks, fetal arrhythmia, myocarditis, cardiomyopathy, heart failure, valvular insufficiency or obstruction, it can be detected late, and cardiac tumor have variable onset, depend on the size. In addition, small ventricular or atrial septal defect, minor valve lesion, partial anomalous of the pulmonary venous connection, and coronary artery anomaly are often not detected antenatally. When we convert our routine basic fetal echocardiography to detailed, if you have abnormal situs, if you have chamber asymmetry, if you have arrhythmia, if you have abnormal cardiac access or abnormal heart size. So it gives you back to the detailed assessment. Okay, just I will go quickly about some image because my time is almost finished. This is, see, no one should diagnose this as for chamber view. There is only one chamber which you can see clearly, one atria which you can see clearly, and this is close to the chest wall. So this is what? This is left hypoplastic. So this should not be missed, although unfortunately it is missed. Okay, this is video, but it is not working. Okay, this is ventricular septal defect. This is VSD inlet. This is muscular, and this is perimembranous. Okay, all these can be detected better in transverse view. This is, you can see here, you can see there is defect, which is arrow here for the defect. But when you go to transverse, you see it more clearly with the proper insonation perpendicular to the interventricular septum. What is this? We said that the normal is to have that mitral valve is more toward the basal and the tricuspid valve more apical. But it is not to this extent. It's supposed to be here. When it is more toward apical, this is Obs-Gyn anomaly. This is again a case of Obs-Gyn anomaly. See, this is left ventricle and left atrium, pulmonary vein. See the right, it is just this small right ventricle, and this is all right atrium. So this is a case of severe Obs-Gyn anomaly. It present at 21 week with this anomaly and mild hydrops. It progress. Unfortunately, this baby, although all the chromosomal abnormality was ruled out, we did even whole exome sequencing, but this baby, because of the heart condition and the hydrops, could not make it. So this is again, what is here? It is this one. This is left. There is mitral atresia. So you can see that this is the right ventricle and this is the left. Size is different and there is no inflow in the left side. This is cardiac tumor, which can be detected at any gestation, depend on the size. This is, you can see here, this is due to persistence of left superior vena cava. You can also see it and confirm it by 3-vessel view. This is clear. The left side, you can see while the video moving, stomach is down, left is down. So this is, this baby will be in breech again, okay, because spine to my left. You can see moderator band, you can see both valves is working, but this is left hypoplastic heart. See the size of the two chamber. Okay, this is, there is mediastinal shift. Also heart looks normal, 4-chamber, LVOT, RVOT, but see the stomach is in the chest. So this is diaphragmatic hernia. We should not miss it. This is, you cannot see septum primum, and there is defect also in the ventricular septal defect inlet. So this is what we say cracks. There is defect in the cracks. This is atrioventricular septal defect, which is commonly seen with Down baby. Okay. My apology. This case was referred. There is mass on the chest. So we look to the abdomen. Stomach is down. So this is what we are seeing is not the stomach. So what it is, this is something called left ventricular diverticulum. It is rare anomaly, but we can see it here clearly. This is left ventricle, this is the diverticulum. Okay, this is again, this is right, this is left, this is mitral atresia. Okay, I'm sorry, seem to be, it is repeating. Okay, this is, see here, this is the right ventricle, it is completely occluded. So it is not functioning. And this is like left is down, right is up. This is like right hypoplastic heart. So just I'm showing you all this quickly to tell you by 4-chamber, you can diagnose so many anomalies. Yes, the detection rate will increase if you add the outflow. You look to this case. Okay. This is right, with moderator band. This is left. And you cannot see the septum secundum. This is a case of atrial septal defect. Patient was seen at a 26-week, 3 days. Although we tried our best to see everything, we thought that pulmonary vein is present here, but unfortunately, color was not helping in this case. And then it was again after delivery, it was that there is no pulmonary vein, total pulmonary anomalous. Okay, this baby already delivered. Also here, something looked like, but we didn't see it entering. So it is atrial septal defect with total pulmonary anomalous. So we can miss, yes, we are human being to miss, but we should not keep ourselves to the level that, okay, it looks normal. Please, please, my message, which is the take-home message, I'm sorry, I passed more than my time, so I'm going to stop. Actually, I reached to the end. That page was showing you all the level that we need to get by transverse view to detect all the anomaly, hopefully. But the only message I would like to pass before I conclude, that if you are not seeing clearly, don't imagine and say, no, it looks normal. No, it is not clear to me. So I need to go and check it, make sure it is normal, or refer it to somebody who can do it better than me. Thank you for tolerating me for more than half an hour. I hope it was beneficial to all.
Thank you very much, Dr. Muna, for the excellent presentation. I am very sure that all the videos were excellent quality and it has kept the audience glued to their screens. Thank you again, Doctor.
Thank you, Dr. Manjula.
We will keep the discussions for the last. After all the 4 lectures, we'll keep the discussions. So I think Dr. Manjula can go ahead with the next lecture.
Yeah. I think my screen is visible.
Yes, doctor, please.
Good evening. I'm going to present something about surgical site infections in obstetrics and gynecology. This subject is a little close to my heart, as I was involved in surgical site infection audits in the last 3 to 4 years in my hospital tenure in Al-Qasmi Women and Children Hospital. I have nothing to disclose, nor do I have any conflicts of interest. However, I'm thankful for VitaBiotics for allowing me and giving me this opportunity to present today. Today's learning objectives are to discuss about how to mitigate or prevent surgical site infections and its management. I focus mainly on evidence-based approach methods before, during, and after the surgery to minimize the risk of infections. And at the end, I would give you some recommendations about the approach to surgical site infections as well. Why is surgical site infection so important? Surgical site infections significantly affects the quality of life. They cause considerable morbidity and extended hospital stay, considerable financial burden to both the patients and the healthcare providers. Surgical site infection is the second most common cause of hospital-acquired infections, even in high-income countries like United States of America and Europe. Highest incidence is seen in colon surgeries, which is about 9.5%, followed by coronary artery graft bypass surgeries, which is about 3.5%, cesarean sections about 2.9%, cholecystectomy in 1.4%, and it is least seen in knee prosthesis, which is about 0.75%. The epidemiology of surgical site infection, the overall incidence is about 2 to 6% in surgeries seen in high-income countries. In Italy, I have found out some countries where they have declared the surgical site infections. This is as per the WHO. Italy is about 2.6%, France 3%, Switzerland 5.4%. In England, Overall surgical site infection was seen in 5% of cases. However, in abdominal hysterectomy, it was the least, 1.9%. This was reported in 2018 and 19. In United States of America, and after hysterectomy, it was seen in 2.7% of the cases. In Sweden, it was almost the same in LSCS and also in abdominal hysterectomies. However, a high incidence was seen in vaginal hysterectomy. Worldwide, surgical site infection following cesarean section is seen in 3 to 15% of the cases. There is a huge range, 3 to 15%. Probably because of different denominators usage, different incidence of LSCS in different countries, presence of comorbidities, prophylaxis, there is a difference of opinion usage of prophylactic antibiotic, the grade of the surgeon, and the techniques used. The type of surgery is highest surgical site infection is seen in large bowel surgery, which is about 9.5%, which is expected. 2/3 of the infections are superficial and 1.1% are deep and organ space infections. Coming to the wound classification, before we go into the different types of surgical site infection, I would just like to brief on wound classification. Clean wound is something which is made under sterile conditions where there are no organisms present. So the skin should likely to heal without any complications. For example, the commonest surgery is, an example for this kind of surgery is a skin incision for ovarian cystectomy. Clean contaminated wound is a wound which is made under surgical sterile conditions, but in which the respiratory, gastrointestinal, genital, or urinary tract is entered under controlled conditions and without any unusual contamination. For example, it's hysterectomy or a cesarean section. Contaminated wound is a typically open, fresh, or accidental wound or an incision which is undertaken during an operation in which there is a major break in sterile techniques or gross spillage from GI tract contents. This is seen in Obs-Gyn surgery when the bowel is opened deliberately or accidentally. Dirty and infected wounds, we all know that already it's infected and pre-existing organisms are present. Example is laparotomy for pelvic collections. Now coming to the surgical site definition and classification. Surgical site infection is defined as an infection of the superficial or deep skin incision or of an organ space which occurs up to 30 days after surgery without an implant and within 1 year with implant in place. This is a picture which shows the 3 different varieties of surgical site infections. Superficial surgical infection, which is involving only the skin and the subcutaneous tissue. Deep incision, incisional SSI is deep soft tissues like fascia and the muscle is involved. In organ space infections, you all know that it's the peritoneal cavity and the other organs are involved. There are definite set criteria in each one of these. The criteria to diagnose superficial wound infection is at least one of the following should be present: purulent, effluent, or exudate with organisms identified. Presence of one of the following like pain, redness, localized swelling, tenderness, or heat, or diagnosed by surgeon or attending physician. Criteria to diagnose deep wound infection is, for deep wound infection, at least one of the following should be present: purulent exudate from a deep wound incision, spontaneous dehiscence of a deep incisional wound, or a wound which is deliberately opened in the presence of pyrexia of more than 38 degrees, localized pain or tenderness, evidence of abscess or infection involving deep wound incisions found on direct examination of the wound during reoperations, radiologically or on histology. Diagnosis of a deep incisional wound infection by a surgeon or an attending physician. So in all these 3 different types of surgical site infections, even a clinician's diagnosis can be taken into consideration, even if the cultures are negative or there is no pus which is coming out through it. Criteria to diagnose organ or space infection, at least one of the following should be present: purulent exudate from a drain which is placed in the organ or space via a stab wound, organism isolated from the organ or space, evidence of abscess or infection involving the organ or space which is found on direct examination of the wound during reoperation, radiologically or on histology. Diagnosis of an organ or space wound infection by a surgeon or an attending physician. The commonest bacteria which are seen in gynecological infections is usually polymicrobial, but it will be most commonly from the skin and genital tract flora. Staphylococcus aureus and coliforms such as E. coli and Proteus mirabilis are the commonest isolates seen in most of the studies. So these are the group of bacteria which one can encounter in surgical site infections. Among the gram-positive aerobes, it is mainly the Staphylococcus aureus and Enterococcus, GBS, Staphylococcus pyogenes, Staphylococcus epidermidis, and MRSA. And among the gram-negative anaerobes, Klebsiella is most common, E. coli, Pseudomonas, Proteus, and Klebsiella species. Among the anaerobes, Clostridium, Gardnerella vaginalis, Fusobacterium, Bacteroides fragilis, Peptostreptococcus, and Prevotella. Now, coming to the preventive measures of, after this brief introduction to the surgical site infections, we will go to the preventive measures. There are various places where a surgeon can act to bring down or mitigate these surgical site infections. We broadly classify them into patient factors like smoking, body mass index, perioperative hyperglycemia, depth of subcutaneous tissue, which is more than 3 centimeter, coexistent infections, vaginal colonization, MRSA status, and immunodeficiency status. Preoperative measures can be taken. Intraoperative preventive measures could be applied, and also the postoperative measures. All could help in mitigating surgical site infections. Coming to the risk factors, again, the patient factors, again, I'm just quickly going through them. Age, obesity, diabetes mellitus, place of residence like rural areas, smoking, immunosuppressions like steroid usage, alcohol usage, poor nutritional status, length of preoperative hospital stay, anemia. Preoperative and pre-pregnancy risk factors like hypertension in pregnancy, gestational diabetes, multiple pregnancy, previous cesarean section, skin preparation, hair removal, type 1 and type 2 diabetes mellitus, ASA minimum grade 3, pre-hospital stay of 2 days. Intraoperative and intrapartum risk factors like frequent vaginal examinations, prolonged rupture of membranes, prolonged labor, chorioamnionitis, emergency cesarean sections, prolonged surgery, poor surgical technique, surgical drains, non-use of antimicrobial prophylaxis, primary PPH, intrapartum pyrexia. Postoperative factors like hematoma formation, blood transfusions, and a prolonged hospital stay. All these are considered as risk factors for surgical site infections. I'm sorry for this busy slide, but I couldn't omit even one of them because they're of high importance. The preoperative measures to mitigate surgical site infections are shower or bath, which can be taken on the day of surgery or 1 day before using soap. However, the evidence doesn't suggest any antimicrobial soaps are better than normal soaps. Nasal decolonization, consider nasal mupirocin in combination with a chlorhexidine body wash before the procedure, in which Staphylococcus aureus will be the likely cause. We need to use hospital recommended MRSA protocols or adjust the prophylactic regimen of antibiotic to include a single dose preoperative IV vancomycin in these cases. Perioperative screening and treating bacterial vaginosis is essential before hysterectomy. All infections, even remote to the surgical site like skin, urinary tract, should be identified and treated before elective operations. WHO recommends use of protocols for intensive perioperative blood glucose control for both diabetic and non-diabetic adult patients undergoing surgical procedures to reduce the risk of SSI. It is a well-known fact that stress causes hyperglycemia because of the excessive release of catecholamines. At the same time, it inhibits the insulin production by the beta inlet cells of the pancreas. So in these two risk factors can cause perioperative hyperglycemia. So a target blood glucose level of 7.8 to 11.1 millimoles, that's about 140 to 200 milligram per deciliter, is recommended. In Al-Qasmi Women and Children Hospital, we do this random blood glucose monitoring for 3 days as long as the patient stays postoperatively in a hospital. However, there is insufficient evidence to recommend a strict control. Do not use hair removal routinely If it has to be removed, hair clippers are recommended on the day of surgery. Use appropriate theater wear for the patients. All theater staff should wear specific non-sterile theater wear in all surgical areas. Hand jewelry, artificial nails, and polish should be removed before surgery. I give single-dose antibiotic prophylaxis based on the type of the surgical procedure on starting the anesthesia or within 60 minutes of incision. Hand decontamination, wash using aqueous antiseptic surgical solutions with a single-use brush and pick for the nails. This should be for a minimum of 3 minutes. Before subsequent operations, alcohol hand rub solutions like Avogard, for example, or an antiseptic surgical solution can be used if the hands are not soiled. Use iodophore impregnated drapes or incised drapes routinely, as they are known to reduce the risk of surgical site infection. Surgical team should wear sterile gowns and use double gloves. Skin preparation, the first choice is alcohol-based solution of chlorhexidine. That's about 2% chlorhexidine in 70% alcohol solution. For example, Soluprep. Alternative is 10% povidone iodine solution. Chlorhexidine is considered bacteriostatic and alcohol is bactericidal. The idea behind using chlorhexidine is the antiseptic action lasts even after the surgery for a longer time. So it's good to use chlorhexidine-based solutions. Vaginal cleaning with either 4% chlorhexidine or povidone iodine should be considered before doing a hysterectomy. This is as per the ACOG guidelines. Maintain the patient intraoperative temperature as normal. Optimal oxygenation and adequate perfusion should be maintained during surgery. Use of goal-directed fluid therapies intraoperatively is advisable to reduce the risk of surgical site infection. This helps to maintain adequate tissue perfusion. Do not use diathermy for surgical incisions and also avoid staplers for skin closure in cesarean section. It has been proved that skin closure with staplers causes superficial wound dehiscences, especially in cesarean section. Minimize the risk of wound disruption with excellent surgical techniques, effective hemostasis, gentle tissue handling, removing the devitalized tissues, eradicating dead space, and appropriately managing postoperative incisions. There is insufficient evidence to recommend for or against the use of wound irrigation or intracavity lavage to reduce the risk of surgical site infection. WHO recommends to consider use of irrigation of incisional wound with an aqueous PVPI solution, that is iodine-based solution, before closure for the purpose of preventing surgical site infection. However, NICE advises it to be used only as a part of clinical research trial. This is as per the NICE guideline on surgical site infection, number 125. Consider sutures for the skin closure over staplers in cesarean section. Consider antimicrobial triclosan coated sutures for wound closure in all types of surgery, recommended by WHO and NICE as well. So these are some of the examples which I have put across. There may be some other which are available in your hospitals and in market, but this is what we use in our hospital. The last one is the sponge with a pick which is there, which contains chlorhexidine 4% with alcohol. And in between the surgeries, we can go with this Avogard, again chlorhexidine-based alcohol solution. And this is what is Soluprep, which we use to paint the abdomen before incising. So this also contains chlorhexidine. Postoperatively, drain. WHO suggests that perioperative antibiotic prophylaxis should not be continued in presence of a wound drain for the purpose of preventing surgical site infection. It also suggests removing the wound drain when clinically indicated. No evidence was found to recommend an optimal timing for wound drain removal for the purpose of preventing surgical site infections. Consider the use of prophylactic negative pressure wound therapy in adult patients on primarily closed surgical incisions in high-risk wounds, especially in diabetics, smokers, morbidly obese patients. This is the current recommendation by WHO and NICE as well, but we have to keep the economic conditions in mind as well. So it cannot be taken as a strict guideline or a criterion. Use aseptic non-touch technique for changing or removing surgical wound dressings. Use sterile saline for wound cleaning up to 48 hours after surgery and tap water after that. Patient may shower safely 48 hours after surgery. Do not use topical antimicrobial agents for surgical wounds which are healed by primary intention. Ask appropriate healthcare professional or wound care nurse for advice on appropriate dressings for management of surgical wounds which are healed by secondary intention. So this is one such in the prophylactic negative pressure wound therapy device which we are currently using in our hospital. As I said, I don't have any conflicts of interest. However, this device is quite good. This is how it comes in a box, a sponge which is connected with the suction apparatus, and this is a battery which is connected to the suction catheter. After the dressing is applied, the the machine is put on, so the whole sponge is getting sucked inside. So it becomes a flat dressing. You need to put your the normal dressing on top, which we are going to put this sponge dressing. So this battery, this has got a container which keeps sucking the lymph, whatever the seromas or whatsoever the seropurulent discharges which gets collected over time in this jar. This dressing is kept for 7 days, and it has a belt where the patient can tie it on her waist, and this battery can be fixed to that. The patient is called back after a week in the clinic, and we discard this fluid and we are going to remove this dressing. We have found quite good, impressive results using this Prevena. Assessment to consider antibiotic prophylaxis. This is one of the important step which everybody should consider. Every patient undergoing surgery should be assessed for an antibiotic prophylaxis need based on the nature of the surgical procedure and the wound classification, the complexity of the procedure, the duration of the procedure, risk of post-surgical infections, consequences following the surgical site infections, usage of any prosthesis or any implants, and the patient factors. Any underlying medical conditions can predispose to certain pathogens. So every patient has a right to go for the usage of antibiotic prophylaxis. And how do we select them? The antibiotics should cover only the likely pathogen based on the nature of the surgical procedure and the type of the wound, also considering patient factors and the knowledge of the community epidemiology. Select an antibiotic with narrowest antibacterial spectrum. Predominant organism after any clean procedure is Staphylococcus aureus and coagulase negative staphylococci. In clean contaminated procedures, it's mixed infections. So you can encounter gram-negative rods and enterococci along with the skin flora. The duration of antibiotic prophylaxis is single dose usually. Post-operative extension is not recommended unless infection is confirmed or suspected, regardless of the presence of the drains or intravascular catheters. If at all needed, it should not be extended beyond 24 hours. History of allergy to antibiotics to be carefully checked. However, a test dose is not mandatory or necessary. Gentamicin as prophylaxis can be used as a single dose only. So this is the recommended antibiotic prophylaxis in Obs-Gyn procedures. All kind of abdominal hysterectomy, vaginal, laparoscopic, robotic, all can receive cefazolin 2 grams. And if the patient is weighing more than 120, we can consider giving 3 grams. And in case of vaginal procedures like colporrhaphy, colpoperineorrhaphy, or vaginal sling placement, we can still give cefazolin. And in uterine evacuations, we'll give doxycycline 200 milligram just before the procedure. And in all other cases, like minor procedures, what we come across, like cervical tissue excision, cystoscopy, endometrial biopsy, laparoscopic procedure, even though it's an advanced procedure, still, as there is no vagina which is entered or bowel which is breached, so it doesn't need any antibiotic. However, laparotomy is considered same as cesarean section, so we can consider giving cefazolin. In spite of seeing all these kind of clear-cut cases, still we might encounter some special circumstances which needs an additional dose. Like intraoperative redosing can be considered if the procedure duration exceeds 2 half-lives of the selected drug measured from the time it is given. or if the intraoperative blood loss is more than 1,500 ml. In obese patients, consider 3-gram IV cefazolin if the weight is more than 120 kilograms. Or in patients who are already on antibiotics, what to do, which antibiotic to choose. Continue on the antibiotic as deemed necessary by the treating physician. If an appropriate antibiotic, it can be rescheduled to be given within 60 minutes of surgical incision. If this antibiotic doesn't cover the spectrum, the preferred preoperative agent should be given within the appropriate time frame prior to surgery. If preoperatively the patient is colonized with MRSA, or if there is any past history of MRSA, vancomycin addition should be considered. However, vancomycin and quinolones need to be given a little much in advance because the tissue level takes little longer time to reach. So you might need to consider giving it 120 minutes before the surgery. Coming to the timing of the antibiotic, optimum timing to achieve high concentration at the incision site at the time of incision should be given. Consider either at the time of initiation of anesthesia or within 60 minutes of incision. NICE guideline recommends to be given at the initiation of anesthesia. However, WHO says it's up to 120 minutes, but in our hospital, we practice within 60 minutes of incision. Some agents like azithromycin, vancomycin, quinolones require prolonged infusion over 1 to 2 hours. So infusion should start within 120 minutes before the incision. We did all to reduce the surgical site infection by all kind of measures. Still, we still encounter cases of surgical site infection. What should be the approach to them? Usually, surgical site infections happen 4 to 7 days postoperatively after cesarean sections or any major gynecological surgeries. The signs and symptoms will be usually fever, purulent discharge, signs of inflammation may be there like induration, tenderness, and erythema. Minor superficial infections just need removal of the sutures, need abscess drainage, topical antisepsis, may not always require antibiotics in superficial infections. We need to collect swabs, CBC, CRP, and blood cultures as well. Use broad spectrum antibiotics if needed. Imaging may need to be done to exclude intra-abdominal collections, like ultrasound, CT can be done if the patient has persisting fever or suspected pelvic collection. What antibiotics to use in these cases? Already patient has received preoperative antibiotic and now she comes with infection. Still, first line antibiotic should be penicillin. Usually it is coamoxiclav or cephalosporin with metronidazole. If the patient is allergic to penicillin, consider giving clindamycin or vancomycin. If the patient has persistent fever, we can add gentamicin to this. In superficial infection with cellulitis, this is mainly because of group A streptococci. Flucloxacillin is better in these cases. In deep infections, pelvic collections, they may need surgical exploration and drainage of abscess, wash and drain insertion. Radiological drainage can be considered in patients with multiple comorbidities where we don't want to do a relaparotomy. However, these procedures are usually unsuccessful as the abscesses are multiloculated. Wound debridement and secondary closure can be may be needed in some cases. Necrotizing fasciitis, a few words about this. This is a very uncommon infection which occurs in 1.8 cases per 1,000 cesarean sections. It's mainly polymicrobial, where almost all kind of bacteria can be involved, both aerobes and anaerobes. Group A streptococcus and coliforms are the most common in these infections. Cellulitis, which fails to respond to the antibiotics, edema beyond the erythema, ecchymosis, vesicles, crepitus, these are the hallmarks of necrotizing fasciitis. We can do a CT, MRI, or a plain X-ray, which may show gas. Treatment is antibiotics and surgical debridement. So in brief, I'm just going to summarize my talk by giving some few take-home messages. Use of surgical site infection reduction bundles is recommended, which include prophylaxis, skin preparations, avoiding hypothermia intraoperatively, avoid as much as possible to use drains, and reducing intraoperative hyperglycemia. Identify modifiable patient risk factors preoperatively and advise lifestyle changes. Reduce preoperative hospitalization to a minimum. It is considered good practice to screen for MRSA status and to decontaminate the woman undergoing surgery in obstetrics and gynecology. NICE advises that patients should shower or have a bath using soap the day before or on the day of surgery. Prolonged surgery is associated with a higher rate of surgical site infections. Studies have reported a surgical site infection rate of 6.3% for a surgery which is less than 1 hour duration to increasing to almost fourfold, 28% for surgeries lasting more than 2 hours. Redosing of the antibiotic is therefore recommended if the surgery is prolonged more than 3 hours, especially in a hysterectomy, and blood loss is more than 1,500 ml. NPWT or negative pressure wound therapy is a wound management technique in which a vacuum dressing is applied to promote wound healing. This is recommended by NICE. Do not prolong the prophylactic antibiotic as it does not reduce the surgical site infection, rather it causes resistance, antibiotic-related morbidity, and increases the healthcare costs. Enhanced early recovery is especially very ideal. What we usually practice in laparoscopic surgeries can be done even in routine surgeries as well, where we do early mobilization and discharges. This is also an important factor in mitigating surgical site infections. And these are my references. Thank you very much. Now, may I call upon Dr. Naila to present her presentation. Dr. Naila is an acting consultant at Al-Qasim Women and Children Hospital, and she's working in UAE for the past 12 years. Dr. Naila has special interest in auditing cesarean sections, and she has special recommendations even there. Dr. Naila, the floor is yours.
Hi, thank you, Dr. Manjula, for your introduction. Thank you for the nice presentation. Thank you. I will just share my screen. Are you able to see my screen?
Yes, Dr.
Yes, doctor. Yeah.
Okay. Thank you so much. Thank you, Dr. Manjula. Good evening, everyone. First of all, let me thank you all for joining here today. My today's talk is about interpretation of Pap smear. Interpretation of Pap smear, why we choose this topic, the reason behind is that in a recent couple of years, there is a total paradigm shift from the cervical cytology screening. So we thought, let's summarize it and let's talk on it. So objectives of this today's talk are that to understand different components of Pap smear report. Usually we are worldwide also, and in our local practices, we are using Bethesda system for cervical cytology reporting. So mainly I focused on to understand the components of Bethesda system reporting. And the second objective is to just catch on cervical cancer screening program in UAE as well as internationally, and also to go through the management strategies. Briefly, we will discuss the management strategies of abnormal Pap smear and the referral pathways for colposcopy in cases of abnormal Pap smear. The current reporting system, what we are using is basically 2014 Bethesda system. Bethesda system is basically started in 1988, and it was December 1988. On one snowy weekend, there was a small meeting in the National Institute of Health Sciences in Bethesda, which was in Maryland, USA. And no one at that time knew that this small meeting will make the basis of a new system of cytology reporting, not only locally, but internationally, worldwide. Now everyone is using, not only for cervical cytology, but also for other cancers, precancerous lesions reporting for other cancers, other sites cancers. So Bethesda system basically They have updates 3 times. They have updates after 1988. It was first was in 1991, then in 2001, and then they have the last update in 2014, which we are following right now. Now we will go through just briefly the components of the cervical cytology report. Basically, Bethesda system reporting has certain specific criteria. First of all, they have to mention in the report that there is what kind of smear it was made. They call it specimen type, either it's a conventional pap smear or a liquid-based preparation. And then they have to mention the specimen adequacy, that is the specimen satisfactory for evaluation or unsatisfactory for evaluation. We will discuss what are the criteria for satisfactory evaluation in the later slides. Here, just stepwise, I will tell you how the general categorization and what components of the reporting are. Then the second one is optional. Some laboratories are mentioning the general categorization and some are not mentioning because it's optional from the Bethesda system itself. General categorization, under general categorization comes the negative for intraepithelial lesion or malignancy, or some other findings like endometrial cells in a woman of more than 45 years of age. It is important, so some laboratories have to mention it. Then epithelial cell abnormalities. So 3 basic components, either it is negative or some abnormalities or some other findings are there. And then comes the interpretation or results. In the interpretation section, they have to mention either it is negative for intraepithelial lesion or malignancy and what comes under this. There are some normal cellular elements, which are squamous cells, obviously, endocervical cells, endometrial cells, and lower uterine segment cells. And then non-neoplastic cellular variations. Some non-neoplastic cellular, these are the first was the cellular components, then the non-neoplastic cellular variations. In these cellular variation comes the squamous metaplasia, some keratotic changes, tubal metaplasia, atrophic changes, pregnancy-associated changes. They all comes under non-neoplastic cervical variations. And then some reactive cellular changes, some changes which are in the cervical epithelium, which are related to repair and inflammation and repair process. They all come in. We will go through them in the detail later on. It's just for enumerating them. And some changes are related to inflammation, some cervicitis, radiation-related changes. Some changes are related to IUDs, intrauterine contraceptive devices, and some glandular cells post-hysterectomy are also comes under reactive cellular changes. And then some in the pap smear report, sometimes they mention if they find the organisms like Trichomonas vaginalis, some Candida species, bacterial vaginosis, actinomyces, which is mostly due to IUDs, then cellular changes consistent with herpes simplex, cytomegalovirus. There are some organisms which cannot be reported on pap smear or which cannot be seen on pap smear are chlamydia and gonorrhea. So other than that, these organisms can be seen in the pap smear and can be reported in the pap smear. And then some other findings, which I told before, like endometrial cells, they are significant if they are in the pap smear of women more than 45 years of age. These were the normal cellular variations. Now we go to the epithelial cell abnormalities. What epithelial cell abnormalities can be reported in the pap smear? First, squamous cell abnormalities, then glandular cell abnormalities. In squamous cell abnormalities, there are atypical squamous cells and some atypical squamous cells of undetermined significance, or atypical squamous cells which from which high-grade lesion cannot be excluded. And then low-grade intraepithelial lesion, and then high-grade intraepithelial lesion, which encompasses moderate and severe dysplasia, like SIN2 and SIN3. And then with features suspicious of invasion. And then comes the squamous cell carcinoma. This completes the squamous cells. And then we go to the glandular cells. In glandular cells, there are 2 types of atypical glandular cells. One, atypical glandular cells are those which cannot be otherwise specified. I mean, they are atypical, but they cannot be specified otherwise. They are not like this glandular cell entity is analogous to the ascus of squamous cells. But in glandular cells, because glandular cells are more high risk, so they cannot confuse it with the squamous cells of undetermined significance. So they have kept them directly as endometrial or endocervical cells, which are not specified otherwise. And then atypical glandular cells which favor neoplasia. That is a separate entity. And you notice that in that endocervical cells are there and glandular cells are there, but endometrial cells are not. We will discuss it later why it is not there. And then comes endocervical adenocarcinoma in situ, and then adenocarcinoma. And adenocarcinoma can be endocervical, endometrial, or extrauterine, or not otherwise specified, which they cannot specify the origin of the carcinoma. And then comes, after these epithelial abnormalities, then comes the other malignant neoplasm. If they have seen in pap smear, in any other malignant neoplasm, then they have to specify it. And then if you are doing with pap smear some adjunctive testing like HPV or cytochemistry or any other adjunctive testing you are doing, then lab has to mention in the report. And if pap smear reporting is computer assisted, then also you have to mention in the report what automated device you are using. You have to specify the name and the results of that report. Then this is another optional thing which can be mentioned in the reporting, pap smear reporting, which is educational notes, and it depends on the cytologist who is reporting the. So now one by one we will go to these components in detail. So first thing comes adequacy of the smear. What is adequacy of the smear, and what does it mean, and why it is important? What is its significance? Before going to the detail of adequacy of the specimen, I will show you some sample reports which can maybe give you an idea that what adequacy of the specimen is. In example number 1, you can see that it's written endocervical, it is satisfactory for evaluation, endocervical or transformation zone component present, and the interpretation is negative for intraepithelial lesion or malignancy. Okay, second example is this specimen also is satisfactory for evaluation, endocervical or transformation zone component absent or insufficient, but it is satisfactory for evaluation. And the interpretation is again negative for intraepithelial lesion or malignancy. We will go for this management section later on, so I'm not going to discuss it right now, just to go through the examples now so that you can understand what is adequacy of the pap smear and what are different criteria which tell us that this sample is not adequate for evaluation. So in example number 3, you will see that this sample is unsatisfactory for evaluation. Why? Because specimen processed and examined, but unsatisfactory for evaluation of epithelial abnormality because of obscuring inflammation. And the comment is trichomonas vaginalis identified, and consider repeat cervical cytology after treatment of trichomonas. Then in another example, that this specimen also is unsatisfactory for evaluation of epithelial abnormality because of insufficient squamous cellularity, partially obscuring blood identified. So now in comment, they have written endometrial cells present and consistent with day 5 of LMP, last menstrual period. As we will see that why LMP date is important when you are sending a sample for a pap smear. And the next example is, this is also an unsatisfactory specimen. Why? Because the vial which was received to the lab was unlabeled. So if vial will be unlabeled, it will be again an unsatisfactory smear. So now we will go in the detail what is the basic criteria for adequacy of the specimen. Basic criteria for adequacy of the specimen is the minimum squamous cellularity. If minimum squamous cellularity is present and the cytologist is able to see at least 5,000 well-visualized, well-preserved squamous or squamous metaplastic cells, then this specimen is adequate for specimen, adequate for evaluation. So now we will see that, okay, what is presence of transformation zone? Why, if transformation zone is absent, it cannot be inadequate smear. This is not the criteria for adequacy of the pap smear, but the labs have to mention that the transformation zone is absent or insufficient, or it is not present. the presence of transformation zone sampling is not necessary for an adequate specimen, only squamous cellularity that I mentioned before. However, laboratories have to mention that the transformation zone is absent because it's useful for quality assurance measures. So it shows that how the physicians in the facility are taking the sample and their practices are good or not. If you are getting too many samples with absent transformation zone or insufficient transformation zone, it means that the physicians who are taking the sample are not taking it correctly. So you have to evaluate your quality assurance. And HPV testing appears to be independent of transformation zone sampling. So we will discuss it later, that why HPV testing is so famous now, and now why authorities are adapting HPV testing as more better screening modality as compared to cervical cytology. In 2014, Bethesda system update still recommends reporting the presence of or absence of endocervical transformation zone component as a quality indicator, even though the absence of transformation zone component should not lead to early repeat screening. So any specimen, now another rule is that any specimen with abnormal cells showing atypical squamous cells of undetermined significance, atypical glandular cells or worse, is by definition a satisfactory for evaluation. So how much squamous cellularity you have seen, or you have seen transformation zone or not, but if you have seen atypical abnormal cells, it means this specimen is adequate for evaluation. And why we are focusing more on specimen adequacy, because unsatisfactory specimens are more likely from high-risk patients. So once you are getting inadequate or insufficient pap smear evaluation, it means that you have to repeat it, and then you have to see that maybe this is from a patient who is having hiding a pre-malignant lesion. Obscuring factors also contribute to the specimen adequacy, because sometimes inflammation, blood will obscure the squamous cells and you cannot see them, and it becomes inadequate. The criteria for obscuring factors is that specimen in which more than 75% of squamous cells are obscured should be termed unsatisfactory. Some lubricants also are not, they are the obscuring factors sometimes, because they have some carbomers and carbopol polymers. These are the thickening agents which are used in the gels. But usually what we are using, KY jelly is water-based and it does not have carbomers and carbopols, so we can use it. Now we'll briefly discuss a management guideline for unsatisfactory specimen due to low squamous cellularity. Basic reference is the American Society for Colposcopy and Cervical Pathology. If HPV is unknown, you have done the cytology and HPV is unknown, then you have to repeat the cytology after 2 to 4 months. Nearly all the authorities are advising to repeat the cytology if it is inadequate between 2 to 4 months. And a NICE is guiding to repeat the smear in 3 months, and the ASCCP is asking for repeating it 2 to 4 months. So generally it is after 3 months you have to repeat. If HPV is negative, and you have done HPV along with the cytology and HPV is negative, then you have to repeat cytology after 2 to 4 months. Like if inadequate smear is there, you have to repeat anyway cytology after 2 to 4 months. But if HPV is positive and without genotype, you have not done its high risk or low risk HPV, and age is more than or equal to 25, then you have to repeat cytology after 2 to 4 months or colposcopy. There is option. That if HPV is positive and you're not sure about this, then you have to, it's acceptable. I mean, it's preferable to go for a colposcopy at that time. And if HPV 16 or 18 is positive, no other option other than colposcopy. On repeat cytology after 2 to 4 months, if you have cytology, you have repeated, and now it becomes abnormal, then you have to go through again cytology, second time abnormal, then you have to treat it as an abnormal. We will discuss it later. And if it is negative, go for routine screening if HPV is negative or unknown, or co-testing at 1 year if HPV is positive. And then if again unsatisfactory comes, then you have to go for a colposcopy. It's like if 2 times unsatisfactory specimen comes, then you have to go for a colposcopy. And HPV will guide you that, okay, if you are HPV is negative, then you can do a co-testing after 1 year. And if HPV is positive, then you can repeat it after 1 year. This is nice guideline for if HPV is an inadequate or unavailable cytology. When high-risk HPV test result is unavailable or cytology is inadequate at any screening episode in the pathway, the sample must be repeated in no less than 3 months, as I told you before. Individuals who have 2 consecutive HPV unavailable or inadequate cytology results in any combination are referred for colposcopy. So this rule is also same everywhere. Individuals who have a normal and adequate colposcopy examination should be followed up in the community at 12 months. And if HPV testing is negative at 12 months, individuals are returned to routine recall. So you have to repeat it after 12 months. I mean, once it is negative, then you have to repeat it after 12 months. And again, if it is negative, then you have to ask them for a routine recall. If HPV testing is negative at 12 months, individuals are returned to routine recall. When colposcopy is inadequate, individuals should have a repeat screening test and colposcopy examination in 12 months. If the repeat colposcopy is normal and HPV negative, the individual is discharged for a routine recall. If the colposcopy is abnormal, the management is according to it. Like if colposcopy is abnormal, definitely you have to send for the oncology services. So this is the nice guideline. And before we have discussed the ASCCP for inadequate pap smear. So now we will go briefly to the non-neoplastic findings in one by one in detail. The category of negative for intraepithelial lesion or malignancy is used for the specimens that show a spectrum of non-neoplastic changes, including those associated with protective and reactive responses to inflammation, hormonal alterations, colonization, or infectious organisms. So one by one, we will go like we did it before, that negative for intraepithelial lesion or malignancy. It has normal cellular components like squamous cells and glandular cells, and then lower uterine segment directly sample. Sometimes we take the sample of a pap smear and we directly sample the lower uterine segment. So it has columnar cells that have round to oval, variably hyperchromatic nuclei. So it shows that this sample is directly taken from the lower segment. It's not only the cervical sample. Now we come to the squamous metaplasia. Squamous metaplasia is basically, you all know that it's a process of metaplasia is basically the replacement of one epithelium, like endocervical epithelium, with the squamous epithelium as a protective response. They range from immature parabasal cells to well-differentiated intermediate and superficial squamous cells. So parabasal cells are the most immature cells, and then they differentiate into intermediate, and then the superficial squamous cells are the most mature cells. And metaplastic surface epithelium may eventually become indistinguishable from other squamous mucosa. So in response to trauma, the epithelium, the columnar epithelium changes to squamous epithelium, and in the superficial layer, it cannot be differentiated from the columnar from the squamous epithelium. The histological findings of glandular spaces filled by the endocervical or metaplastic squamous cells beneath the surface will show that this is the cervical transformation zone. Superficially, the cytologist cannot see, but the deep in the glands, the endocervical or metaplastic squamous cells will show us that it's a transformation zone. And this is an indication that the overlying epithelium was once glandular. So in the non-neoplastic cellular variations, I told you before, there are some keratotic cellular changes. This is a second order protective reaction. You can see it in leukoplakia on the colposcopy also. Once after repeated trauma, there is a squamous metaplasia, and then the next order changes, keratotic changes. So it's the next level of protective reaction, basically. And then there's tubal metaplasia. This is a frequent finding in the upper endocervical canal, lower uterine segment, that some tubal metaplastic cells are also there. So they are non-neoplastic, basically. Then we go to the atrophic changes. Atrophic changes are basically epithelium is thin, remarkably thin, and it's made up of entirely of parabasal cells. So usually in postmenopausal pap smears, there will be mostly parabasal cells, which are atrophic cells, and they are most immature cells, and there are no hormones to make them mature. So that's why we see these atrophic changes in the postmenopausal women. Then there can be pregnancy-associated cellular changes. Like in pregnancy, usually under hormonal effect, incomplete maturation. So mostly in the pregnancy, you will, if pap smear is taken during pregnancy, mostly intermediate cells will be the dominant pattern. And they can be misinterpreted as being pre-neoplastic or neoplastic origin, primarily because they may show concerning nuclear features. So it is very important to tell the cytologist that this patient is like pregnant, what is the date, LMP, and what is the age of the patient. All the history is very, very important when the cytologist is interpreting the results. And it is important to be aware of the patient is pregnant or postpartum state to avoid the overinterpretation of these findings. Then other neoplastic findings, which are reactive cellular changes, which are associated with inflammation, physical or chemical trauma, radiation, IUD irritation, or other non-specific causes. Then glandular cells post-hysterectomy, if they are not atypical, post-hysterectomy glandular cells have no clinical significance, and reporting them is optional since they do not change the management. And likewise, I told you that organisms also can be mentioned in the pap smear. Exfoliated endometrial cells in women 45 years or older should be reported. Why? Because they can be associated with benign endometrium, hormonal alterations, less commonly endometrial or uterine abnormalities, but endometrial evaluation is recommended in postmenopausal women, because if patient is menstruating, then the finding of exfoliated endometrial cells in the pap smear is normal. But if the patient is postmenopausal and there is no menstruation, then a finding of endometrial cell is very, very important. So you have to, labs have to mention that if the woman's age is, and it is recommended that if woman age is 45 years or older, and you find the endometrial cells in the pap smear, you have to go for endometrial evaluation. And another important point is that when a woman's LMP is provided and endometrial cells are seen in the first half of the menstrual cycle, then endometrial cells correlate with the menstrual history provided. Like in first half of the menstrual cycle, in the first 12 days, endometrial cells can be frequently seen in the pap smear report, cytology samples. And now we come to the epithelial cell abnormalities. These abnormalities are like, here I have written more on the cytological point of view, so I will not go in the detail. We will go for the management point of view, management section a little faster. So epithelial cell abnormalities, as I told you before, they are atypical squamous cells of undetermined significance, and atypical squamous cells which cannot exclude high-grade squamous intraepithelial lesion. So basically, there is only 10% entity of cells of samples comes under this category, in which this is not a high-grade lesion. It is basically atypical cells, but they are not coming under the high-grade lesion. So they are pre to high-grade lesions. So they mention them as separate. What is the percentage risk of atypical squamous cells of undetermined significance and atypical squamous cells in which high-grade lesion cannot be excluded? Their progression to cancer is, if negative, ASCUS with negative HPV is just 1.1%. ASCUS with positive HPV is 18%. And ASCUS with negative HPV, atypical squamous cells in which high-grade lesion cannot be excluded with negative HPV is 12%, and with positive HPV, it is 45% progression. So basically, HPV is the torch which will show you that where to go. Now, if we will discuss the management of atypical squamous cells of undetermined significance and in which high-grade lesion cannot be excluded. For ASCUS cytology, reflex HPV testing is preferred. Like if you are following the cytology-based screening, then you have to do reflex HPV testing. Like if cytology is abnormal, like SCUS comes, then you have to send HPV testing. Women with HPV negative and negative SCUS, whether from reflex HPV or co-testing. Reflex HPV is that once pap smear becomes abnormal, and then you send a sample for another sample for HPV testing. And co-testing means that you have done HPV testing on the same sample. So either of them is used. Women should return to the co-testing after 3 years. So if HPV is negative and SCUS, then they can come for a co-testing after 3 years, like both HPV and cytology after 3 years. And women with positive HPV with SCUS, whether from reflex or co-testing, should be referred for colposcopy. So this is clear, no confusion in it. When colposcopy does not identify cervical intraepithelial neoplasia in women with HPV positive SCUS, co-testing as 12 months is recommended. So even if colposcopy is negative, then you have to ask for a co-testing after 12 months. And if co-testing is HPV negative and cytology negative, both are negative, then they can go for age-appropriate testing in 3 years. And if all tests are negative at that time, after 3 years, then a routine screening is recommended. Like if you are doing a co-testing, then co-testing is usually after 5 years. So once you will do after 12 months, and then after 3 years, and that is negative, then you will go for a routine screening. And it is recommended that HPV testing in follow-up after colposcopy not be performed at intervals less than 12 months. So if you have to do a repeat screening, then you have to do it not less than 12 months. So at least 1 year you have to wait for the next. For women with SCUS cytology and no HPV result, you have to repeat cytology at 1 year. It is acceptable. And if the result is SCUS or worse, then colposcopy is recommended. Like it's not like one time SCUS comes and you don't have an HPV for triage or telling you which path you have to go, then you can repeat cytology after 1 year. And then if it is SCUS or worse, then colposcopy is recommended. And if the result is negative, then return to cytology testing at 3 years intervals. And for women in which high-grade lesion cannot be excluded, then colposcopy is recommended regardless of HPV testing. And reflex HPV testing is not recommended in these cases. Actually, adjunctive HPV testing is the basic shift from cervical cytology to HPV testing. This is the now main target for almost all the authorities. They are focusing on HPV testing as a basic test for cervical screening. It's because it became a mainstay of triage management for equivocal specimens, specifically like SCUS or low-grade intraepithelial lesion. And co-testing or primary, I told you what is co-testing and primary HPV screening or reflex testing. There are different modalities of HPV testing. Different authorities are using different strategies nowadays. That's why we chose to do this talk, so that we can just summarize that what is going on around us. Then triage of an abnormal cytology result by an HR-HPV test. Why we are using it? Because it's effectively improving the balance of sensitivity versus specificity for the colposcopic referrals. Like there should not be unnecessary colposcopies, and there should not be under-reported cases for cancer. So this is a main target for the physicians right now. While SCUS is the largest category in which this utility is established, usually SCUS is the largest category where we are doing HPV as a triage testing. But it also has been found for other categories, including, like I told you before, like low-grade intraepithelial lesions. And sometimes in patients with atypical glandular cells also, we are using HPV testing. The goal of clinical HPV detection is not detection of all HPVs. That is also important. We are only doing high-risk HPV types. There are 4 high-risk HPV types which are FDA approved for the performance in association with cervical cytology, and 3 of them are DNA-based and 1 is RNA-based. We can not go in the details of these tests, but there are like 4 tests which are used for the high-risk HPV DNA in these days. This is another pap smear report. I will go to the one by one the different abnormalities and briefly their management detail. This pap smear is adequate for evaluation, and description is the predominantly seen are superficial and intermediate cells. A few cells show nucleomegaly with abnormal chromatin pattern, nuclear cytoplasmic ratio is altered, and impression is low-grade squamous intraepithelial lesion. So this is next level of abnormality after ASCUS and now when low-grade squamous intraepithelial lesion comes, what next? This is another report which is showing high-grade squamous intraepithelial lesion. Then what to do when low-grade lesion comes and the high-grade lesion comes? Actually, low-grade and high-grade lesions they encompass the cellular changes associated with, like low-grade lesion is basically mild dysplasia and SIN1. Coilocytes are squamous epithelial cells with perinuclear cavitation. So in low-grade lesions, cytologists will see cells which have vacuolation in the cytoplasm. They call them halo, or they are cleared out appearance around the dysplastic nucleus. What is the management of low-grade squamous intraepithelial lesion? Again, HPV comes on the way. If low-grade lesion with negative HPV result, repeat co-testing yearly. If age is less than 25 years, only cytology is enough, but usually less than 25 years is not, we are not doing cervical screening these days. So if HPV negative and cytology negative, then you have to go for 3-yearly co-testing. And if HPV positive or equal to or more than abnormal squamous cells, then go for colposcopy. And if low-grade squamous intraepithelial lesion, no HPV or positive HPV result, directly colposcopy. There is no confusion in it. So, but now locally, the DOH and MOHAP guidelines, you will find that any low-grade lesion or more than that should be referred for colposcopy, regardless of HPV. So usually we are using this, the previous management guideline, which I have referred, it is basically from American Colposcopic Society. So same as for high-grade lesions. We will not go in the detail of high-grade lesion because this is just a histological detail of the specimen. Management is the same, like if high-grade lesion and more than that, management is not very confusing. You have to go for either for expedited management, direct management, or for a colposcopy. So for high-grade squamous intraepithelial lesions, if women age is 25 years and older, immediate excisional procedure may be performed at the time of colposcopy if a lesion is identified. So immediate procedure, excisional procedure can be performed in these. We should not delay it. If we go to the ASCCP guideline, in women with age more than 25 years, you have two options. Either you should go for immediate excisional treatment, or you can go for a colposcopy with additional histologic and immunologic assessment to confirm the lesion. And in women with age, if you have done a cytology less than 25 years and the high-grade lesion comes, then only colposcopy is recommended. You should not go immediately jump to the excisional treatments. Then squamous cell carcinoma, I will just go through because I think it will take time. So this is squamous cell carcinoma, just histological pattern of this. This is a sample pap smear report showing atypical glandular cells. Now we'll go for the glandular cells. Glandular cells, I told you before that what are the different types of glandular cell abnormalities which can be reported in the pap smear. Interpretation of atypical endocervical, endometrial, or glandular cells defines an increased level of risk. So this we have to mention. Once the glandular cells or atypical glandular cells comes, or we have to be alert. The term atypical glandular cells of undetermined significance is not utilized in order to avoid confusion, as I told you before. It should not be confused with a squamous cell of atypical squamous cells of undetermined significance, because glandular cells, atypical glandular cells are always high risk. So we have to keep them as a separate entity. It should not be confused. An endocervical adenocarcinoma in situ is considered to be glandular counterpart of high-grade squamous intraepithelial lesion and precursor of invasive endometrial adenocarcinoma. However, a low-grade endocervical glandular entity analog analogous to low-grade squamous intraepithelial lesion has not been well established either histologically or cytologically. So that's why these glandular cells description is little different than a squamous cells because of their high-risk nature. Atypical glandular cells should be categorized as to the favored site of origin, like either endocervical or endometrial, whenever possible, because it has a different management strategy that we will see later. Like atypical endocervical cells, they favor, qualified as favor neoplasia.
Dr. Naila, sorry to interrupt you. A couple of minutes more.
Okay, so I will just go through in detail because I want to show the different strategies of the management strategies which are used like these days. So I will just go briefly with the management of atypical glandular cells. Atypical glandular cells, you have to refer to the gynecological oncology services. And definitely the initial management of all categories of atypical glandular cells, except atypical endometrial cells, is colposcopy with endocervical sampling. If woman is 35 years and older or at risk of endometrial neoplasia, they should also have the endometrial sampling. So whenever atypical glandular cells comes, you have two things. You have to either do endocervical sampling and endometrial sampling, both. And those with atypical endometrial cells should have endometrial or endocervical sampling, and colposcopy may be deferred if the endometrial pathology is identified. The repeat cytology is not an option for atypical glandular cell category, as it is high risk and may harbor significant squamous and glandular pre-invasive and invasive diseases. So if invasive disease is not identified on initial evaluation and cytologic interpretation of atypical glandular or endocervical cells favor neoplasia or endocervical adenocarcinoma in situ, the diagnostic excisional procedure is recommended. And HR-HPV positive atypical glandular cell is more likely to have cervical pathology. If it is atypical glandular cells are HR-HPV negative, then it's more related to the endometrial or extrauterine in origin. This slide, I think we will skip because it's all the histological details of the. Just I want to show this Pap smear report, which is of 46 years old women, and the smear is adequate, and smear shows superficial, intermediate, and parabasal cells and a few normal endometrial cells. So what is the significance of normal endometrial cells in the Pap smear? More common when we are, this finding is more common when we are using the liquid-based testing. And it is more common if Pap is done in the first half of menstrual cycle. We did it before also. And if the patient is premenopausal, the cells are benign, no abnormal bleeding, nothing to be need to be done. And if postmenopausal, they need endometrial biopsy. And as I told you before, if the age is more than 45 years and the risk of cancer is more, then you have to go for endometrial biopsy. These are cervical screening strategies which are used currently in UAE. Just briefly, I will tell that what we are using in MOHAB and DOH guidelines. They are updated in 2018 and 2022. All sexually active, symptom-free women, which are 24 to 65 years of age, are eligible for screening. First thing, and then liquid-based cytology is accepted standard method. Now, from age 25 till 29, there is recommended 3-yearly cytology-only screening. We are not doing co-testing. From 30 years till 65 years, there is recommended 5-yearly testing with cytology and HPV as co-testing. This you have to remember, whenever we are doing co-testing, we can do it 5-year, interval can be 5 years. And when we are doing only cytology testing, the interval should be 3 years. And for immunocompromised women, annual testing is recommended. And women who are excluded from screening, they had women who have total hysterectomy for benign indications, or over 65 years who have adequate previous 3 Pap smears were negative, so they are excluded from the screening. And women who have had subtotal hysterectomy, like preserving the cervix, or hysterectomy due to cervical cancer or precancerous condition, should continue to have cervical screening. This is the local guidelines. And now we will, briefly, we'll go to the American Society guidelines in 2020. Now they are saying that before it was like screening was from 21 to 25 years, but now less than 25 years, no screening. From 25 to 65 years, either of the three strategies they are using, either primary HPV testing alone every 5 years, it is preferable, or 3-yearly cytology only, which is acceptable, and then 5-year co-testing with cytology and high-risk HPV, which is also acceptable. And if age more than 65 without documentation of prior screening, should continue screening until criteria of association are met. No screening for women more than 65 with satisfactory prior screening. And what does it mean by satisfactory prior screening? 2 consecutive negative primary HPV tests, or 2 negative co-tests, or 3 negative cytology tests within. So target is that within past 10 years, there should be negative screening. If you are using 5-yearly testing, then 2 tests should be negative. If you are using 3-yearly testing, then at least 3 tests should be negative.
Dr. Naila, time up.
Okay, just give me 2-3 minutes. I just want to show that, okay, what is the current strategy? What is the shift from the cervical screening to cervical cytology to HPV? Basically, American Society of Colposcopy and Cervical Pathology and British Society for Colposcopy and Cervical Pathology have recommended that now they are using HR-HPV testing as a basic cervical screening methodology. And American Society has introduced a new system for screening the cervical cytology screening, which is risk-based. It is not result-based, but it is risk-based. And they have made the different risks for cervical based on the patient whole risk, like previous screening results and patient's age and other risks for the cancer. And then they have made the action thresholds. If the total risk of the patient is to progression to the cancer is 4% or greater, then they have the different categories for the action threshold. Depending on this action threshold, they have different strategies. 1 to 6 strategies they are using, either surveillance for 1 year or 3 years or 5 years, or the second strategy is colposcopy or biopsy. The third strategy is expedited treatment, and then 4th strategy is optional, either expedited treatment or colposcopy or biopsy. These all risks they have calculated and made an Excel sheet separate. It is very easily available on the internet. So if you will go to the internet, you can see using this link, which is mentioned below, you can see this. All the combination of tests and patient's age and all risks they have combined, and then they have given the percentage of risk, and according to that percentage of risk, you will refer them for a 5-year follow-up or 3-year follow-up or 1-year follow-up, or you will refer for the colposcopy, or you will refer for a treatment. And this is basically a pattern of different actions what they are taking on the basis of, if the risk to cancer is 4% or more, then either they have to see that, okay, if risk is from 60 to 100%, then they will send for a colposcopy surveillance. If risk is 25 to 59%, then expedited treatment or colposcopy optional. If risk is 4 to 24%, then colposcopy is recommended. Then likewise, if the major risk is less than 4%, then you have to see that the 3 options of surveillance, either 1-year surveillance, 3-year surveillance, or 5-year surveillance. It is actually very good if we practically try to use it, because they have calculated all the risks and put them in a tabulated form, and it's very easy to see it. Anyway, this is the same now. NHS is using a little different strategy, in which they are saying HR-HPV primary screening is now performed, and they are doing HR-HPV primary screening for all samples, and they are using cytology as a triage test. So this is a little different. So I'm not going through the detail for NHS now. Just a take-home message about after all this discussion is that transition of cervical cancer screening strategy from cytology to HPV testing. Now, world is moving towards HR-HPV testing, and primary HPV testing is preferable method of all. And then if cytology is used as a screening method, it should be more frequent than HPV or co-testing, and it should be 3-yearly cytology. And if you are using primary HPV testing or co-testing, it should be offered every 5 years. And as a general rule, repeated inadequate smears, asbestos, or low-grade changes with HPV positive should be referred to colposcopy services. And if HPV is negative with inadequate or asbestos or low-grade changes, they can have surveillance period of 12 months. And if HPV positive with negative cytology, they can also have a surveillance period of 12 months. For inadequate smears, repeat cytology should be not less than 3 months. So at least after 3 months, you have to, these are just summary points. Whichever methodology you are using, you can use, but then you have to choose the surveillance period according to that methodology. These are my references. Thank you so much.
Thank you, Dr. Naila. May I invite Dr. Aska to present her presentation? Dr. Aska is a specialist Obs-Gyn working in Al-Qasm Women and Children Hospital for quite some time now. Dr. Aska, the floor is yours.
Thank you very much for kind introduction. My slides are visible?
Yes, doctor.
Okay. I express my sincere thanks to Vita Biotics, and it's my honor to be a part of panel in front of my senior consultant and head of the department. After extensive and impressive talk of pap smear, fetal medicine, and infection control, I will try to keep my lecture or presentation very brief. Multiple sclerosis and pregnancy. The learning objectives is a basic disease concept, etiology, prevalence, and course. To understand how to manage the multiple sclerosis in pregnancy with involvement of multidisciplinary team. To understand the effect of pregnancy and breastfeeding on multiple sclerosis. To understand the effect of MS on pregnancy. To understand the importance of pregnancy counseling, safety of the drugs, breastfeeding, and contraceptions. Being an obstetricians, we all of us have been facing and coming across a condition or circumstances when we have a patient who comes and gives the history of multiple sclerosis for her personal history or a past history or some few visits with the neurologist show that the patient is having been diagnosed or taking the prednisolone or corticosteroids, and there's no relapse after that. So being an obstetrician, we should know about the simple knowledge to confidently convey the effect of MS on pregnancy and the effect of pregnancy to MS. Hope I will justify the topic on time. So if we see the basic concept, course and prevalence, we all know it's a chronic inflammatory deep bleeding disorder of the central nervous system. And what happens? It is characterized by neurological relapses and frequent progressive neurological dysfunction and disability. So what happens? The immune system start potentially damaging and inflame the nerve sheath myelin, which cause the conduction defects, neuro and muscular defects. It is more common in the woman than in men, as other immune conditions. The mean age of onset is 30 years of age. So we encounter most of the women who are young or reproductive age, and they are being diagnosed with multiple sclerosis. Half of the women develop the disease during their reproductive year, and the lifetime risk of developing disease in the general population is 1:330. 80% of the people have affected family members. However, it is not a hereditary disease. There is no clear hereditary pattern transmission, but the women who are having the disease diagnosis, they have the family member affected. In the UK, the prevalence in UK is 285.5 out of 100,000 women. So if we see this microscopic diagram, what it shows the fatty layer of the neurons, which is covering by myelin, it's being damaged with the chronic inflammatory process, which subsequently cause the damage of the axon and cause the neuromuscular disability and adverse effects. If we go to the etiology and genetic link, the etiology of the multiple sclerosis is not known. Genetic component is important for risk assessment. And when we go through the literature, it shows that the T cell mediated immunity is a basic reason for causing the multiple sclerosis, but the recent research shows that the role of the B cell is also very important, and which is the basis of use of new drugs in the treatment and the management of the multiple sclerosis. So however, it is not a hereditary disease, but it is impacting and the genetic component is important for the risk assessment. So risk of inheritance with one affected parent is 1:67. If one parent is affected and one sibling is affected, it rises to 10%. The highest risk in monozygotic twin or a children with the both parents affected, which is rose up to 20%. The risk to dizygotic twins is around 5%, and the recurrence risk with one affected child is around 2.7%. They are, along with genetic link, autoimmune condition, and there are some environmental factors which include the viruses. The most common virus which is related to multiple sclerosis is Epstein-Barr virus, the use of smoking, and the obesity also linked to multiple sclerosis. If we see the Gulf region epidemiology, incidence and prevalence, during our consultations with the patients in the clinic, during labor, after labor, and postpartum periods, we come across the patients in our UAE practices. So the latest evidence from the epidemiological studies indicate a high prevalence of MS in Arabian Gulf countries. In the United Arab Emirates, the prevalence was surprisingly high, which around 54.77 out of 100,000 in 2007, and it is considered as a medium to high risk for MS. These are the studies which have been done slightly earlier, 2011 and 17. There's no comparative studies, but the latest studies which are being shown, it is a highest risk. Our region comes in the medium to high risk region of multiple sclerosis. There is a study which is done in 2008. The prevalence of MS in Saudi Arabia was 40 out of 100,000 in 2008. And it is a fairly prevalent underdiagnosed condition and increasingly reporting disorder. There is a Kuwait study in 2005 which shows it is a retrospective study, large study which shows the total prevalence of increase from 6.68 out of 100,000 in 1993 to 14.77 out of 100,000 in 2000, year 2000. And it is more common in Kuwaiti population than in non-Kuwaiti populations. And again, the prevalence was also higher in the Kuwaiti women than the men, which is 35.54 out of 100,000 to 26.65 out of 100,000. These are the reference down. How we categorize the multiple sclerosis. This is the most common type of the multiple sclerosis is a relapsing remitting MS, which is characterized by cycles of relapses and remission. It is most common, around 80%. The secondary progressive multiple sclerosis, it is characterized by infrequent relapses, but with each relapse, the condition worsen. It overlaps between the relapsing remitting and the secondary progressive MS. And the third is a primary progressive MS, which is a progressive worsening of the symptom from the onset of the disease, which account for 10:15%. So when the pregnant woman comes to us as being a gynecologist and an obstetrician, we should know the clinical presentation of MS because most of the pregnancy symptoms are overlapping between the condition and the normal physiological symptoms of the pregnancy. So what are the most common symptoms? It's a fatigue symptom. The patient is complaining of fatigue without having any physiological or biochemical diagnosis. The second is a urinary incontinence, numbness, tingling, loss of balance, dizziness, and vertigo. The visual symptoms are also most common symptoms and can be present as a first symptoms in 20 to 30% of the cases, which is secondary to optic neuritis. Diplopia, poor color vision, acute and chronic pain, spasticity, these all are the most common symptoms in the multiple sclerosis patient. Constipation and incontinence due to nerve damages is also common. The cognitive symptoms, mood swings, clinical presentation, and irritability, this is also common symptoms. Sometimes the patient comes to us and they don't have the symptoms, physiological symptoms, but they are presenting with the mood swings. And we have encountered a woman who have a serious mood swings, and she has a multiple admissions. And for us, it was a difficult time for the patient and the healthcare provider, and the code white was also announced. So these, we being a obstetrician, we should know about the physical and psychological both symptoms which can be presented most commonly for the women who are being diagnosed with multiple sclerosis. The least common primary symptoms include dysarthria, dysphonia, dysphagia, difficult speech, articulation of the speech, difficulty. This is least common symptom. Sometimes the seizures and tremors can happen, the breathing problem, itching over the body, headache, and hearing loss. If we come to the secondary symptoms, which is not directly related, but related to the nerve and the nerve damage and how it manifests as a secondary symptoms, the recurrent urinary tract infections due to incomplete emptying of the bladder and the overflowing of the bladder secondary to nerve damage, it may cause recurrent UTI. Poor postural alignment, trunk control, patient may present as a history of recurrent fall and difficult gait, decreased bone density and increased risk of fracture, and the shallow insufficient breathing. So these are also the symptoms, but these are the secondary symptoms which may present and manifest in the patient of multiple sclerosis. So what happened in the pregnancy? The normal pregnancy, it is a shift from the cell-mediated immunity to the humoral immunity. We all know that the pregnancy is a special state of the changes of the hormones, and the cell-mediated immunity is shift to the humoral immunity, where the fetal placental unit produce helper T cells and cytokine response and interleukin 10. Interleukin 10 is an anti-inflammatory cytokine which play a major role for the maintenance of the pregnancy. So when the interleukin 10 is significantly reduced at time of birth or a term, so the pregnancy ends. And this downregulation favors the pro-inflammatory response at time of birth. And the relapses are common postpartum because of the reason of these cytokines. So this immune responses are explanation that the pregnancy is a state when the multiple sclerosis improves and can be worsened at time of birth or postpartum period 3 to 4 months. So let's see that how it affects pregnancy, how the pregnancy and the lactation effect on multiple sclerosis. There are very reassuring evidences that the pregnancy does not alter the risk of relapse or long-term progression. There are fewer relapses are reported in the literature because of this special shift of the immune system towards the favoring of the pregnancy. The relapses can happen the postpartum period 3 to 4 months. It is not uncommon, and 20 to 30% of the females may present as a postpartum relapse after the delivery. How we can predict the relapse is happening or could be happen? The pre-pregnancy relapse status, the multiparous women are more prone, and the pregnancy which happen after the multiple sclerosis onset. The antenatal immunosuppression explain about the spontaneous remission during pregnancy and exacerbation at the postpartum period. The pregnancy associated with worsening of some symptoms which include the fatigue, back pain, bowel bladder problems, UTI, reduction in mobility, and the increased spasticity. These all are the symptoms of the pregnancy which are commonly reported by the woman, and we consider this as a physiological symptoms if further testings are normal. So we have to be vigilant for the patients who are reporting these symptoms and who has been diagnosed with multiple sclerosis. As we said, it is attributed to pregnancy. They might be, but they might suggest a relapse. So each symptoms, if the patient is having the fatigue symptoms and the patient is coming to us with a fatigue or back pain, it is not a relapse. All the symptoms which are slightly increased or moderately increased cannot be considered as a relapse. There are some specific scale which has to be calculated before considering a relapse. So painful visual loss, optic neuritis, however, suggests a new relapse for a woman who never experienced a visual symptoms. So we have to be vigilant for the referral of the patients and counseling of the patient with the confidence that when the patient is having these symptoms and when there is an overlap of the symptoms and when the patient needs to be referred immediately and there is a potential risk of relapse. So, and lactation and multiple sclerosis, breastfeeding is a distinct hormonal state. And what happened during lactation, the gonadotrophic releasing hormone and the luteinizing hormone, they suppress, which ultimately increase the production of prolactin, which ultimately inhibit the anovulation, which cause the ovulation and lactation amenorrhea. All these factors can cause the reduction in the tumor necrotic factor alpha, which further reduce the CD4 count, which reduce the relapse by fourfold. So this is the very distinct hormonal state, and it has been the mother who is not using any teratogenic medicines. Patients should be encouraged to breastfeed exclusively for the beneficial effect on the MS relapse. And the exclusive breastfeeding, at least for 2 months, has shown to reduce the relapse in immediate postpartum periods in a significant studies. So this was the effect of pregnancy and lactation on MS and how multiple sclerosis is affecting the pregnancy. Let's see. We divide it in maternal effect and the fetal effects, and this is also a reassuring slide. The fertility is not affected by the disease per se. However, some studies shows that anti-Mullerian hormones significantly reduce in the woman with MS. Higher frequency of the voluntary childlessness is reported in this cohort group. Around 22% for the women who are diagnosed with MS, compared to the 13% of the general population. Reason for this voluntary childlessness is disability, the fear of disability, the fear of transmission of the disease to the newborn, the fear of discontinuation of the medication, or sexual dysfunction. Some studies shows that the women who are being diagnosed with the MS, they have the higher rate of hospitalization and cesarean section, and it is the larger national database study. The small increase in operative vaginal delivery is reported with worsening neuromuscular weakness patients. How the MS affect the fetus, the rate of miscarriage, stillbirth, congenital abnormality is not increased, and it is compared to the general population. There is no major increase in adverse outcome for infants. The woman with MS can be reassured about no increased risk of the perinatal mortality. This is a very important and reassuring point, and being obstetrician, we should be confidently counsel based on the meta-analysis and the studies. Yes, there's a small risk of preterm delivery to the woman with the disease manifestation compared to the asymptomatic woman, which account for 8.3 compared to 6.4%. The women who have been having advanced disease with involvement of the organs, they have the risk of more preterm delivery compared to the general population. It is 8.3 versus 6.4%. The woman who has MS, there is a risk of fetal growth restriction, which increased from 1.7 times the general population. So there is a slight increased risk of fetal growth restriction. So how the disease is being treated? There is no cure of multiple sclerosis, as we all know, but the aim of the treatment is to control the relapse, to slow the accumulation of the disease, to slow the disability and progression, to improve the quality of life. So this was the aim. This is the aim of the treatment, of which we say disease modifying therapies, which aim to control the relapse. If the axon is permanently damaged, the medications cannot help to reduce the symptoms. It is the time when the inflammation happens. This is the time when we have to start the medication. And the symptoms depends on the location and the severity of the disease. These are the disease modifying therapies which has been approved by FDA and the European medicine agencies. There are 6 types of medications which are basically immunosuppressive and immune modulators, including polypeptides and polypeptides and monoclonal antibodies. Almost all of these drugs are not safe to use during pregnancy. Except galateramide acetate and interferon, the new evidence says that it can be used with caution during pregnancy and first trimester of the pregnancy. Rest all are category C drugs, category X and D. Yes, steroids can be used with caution before, during, and after pregnancy, with some cautions, and some related condition like diabetes and hypertension should be screened for these women. So if the woman comes to us who is diagnosed with multiple sclerosis, what counseling should be done along with the neurologist? First, it's a reassurance about a non-progression during pregnancy. The approach should be obstetrician, neurologist, physiotherapist, and all related supports. The importance of conception during remission and the good disease control during pregnancy, which gives the good pregnancy outcome comparable with the general population. And we should make the plan with the neurologist with the possible treatment in the event of the relapse, the impact of the disease on the pregnancy and the vice versa, the safety of the medication during pregnancy and breastfeeding, the risk of stopping disease-modifying agents before pregnancy, which are the disease-modifying therapies, the fact that the multiple sclerosis is not a hereditary disease, the risk to offspring is very small. However, there is some genetic link is reported with the multiple sclerosis and some alleles. So generally, we have to reassure about the risk of miscarriage, congenital malformation, and the perinatal mortality is not affected by MS per se. So when the pregnancy happens, so how we will treat the woman? If we have the patient comes with the multiple sclerosis, the overall pregnancies are very smooth and relapses are very uncommon. A multidisciplinary care, neurologist visits, obstetrician with expertise of multiple sclerosis. The pregnancy-related symptoms, which are the exhaustion, tiredness, they may make exacerbations. So the doctor who is treating the woman should know about the symptoms, physiological symptoms, and the most common symptom associated with multiple sclerosis. We should do some simple measures. As with the normal pregnancy, some emphasis should be done for the frequent rest, avoiding stress. Amitriptyline may help to relieve the neurogenic pain. Some extra rest or light duties or the option of the sick leave can be given to the women who are tired and feeling unwell despite not having any relapses. Women with a neurological bladder require monthly mid-stream urine to assess the UTI because of the potential risk of recurrent UTI and the pregnancy. There is increased risk of intermittent self-catheterization for these women because of the nerve damage of the bladder and overextension and overfilling of the bladder. Women need adequate hydration, high fiber diet, and laxatives who experience the constipation. Mobility restricted women should have to assess for the thromboprophylaxis if they require mechanical or they require medical use or heparin. They should be prescribed. MRI is safe in all the trimester. It can be done to assess the relapse or the severity of the condition. if it happens, but we should avoid using the contrast. Gadolinium contrast should be avoided. In cases of acute flare-ups, oral or intravenous corticosteroids are safe. Some special precaution should be done that in case of if the higher dose of the steroid is being used or prolonged use of the steroid, we should at time of birth to avoid the adrenal crisis, we have to give extra dose intravenous or higher oral dose to avoid adrenal crisis. And yes, definitely patient should be screened for hypertension and corticosteroids earlier than the routine. During pregnancy, anesthesia review should be done for pain relief, option during labor. Pethidine, nitric oxide, TENS, regional analgesia is safe. There is some concern, theoretical concern about the use of epidural or regional anesthesia for the woman who's MS, and the procedure or the medication can cause harm to the demyelinating sheath of the nerves. But there's no any study or evidence which prove this risk. So we have to counsel and we have to give the anesthesia review about this, and the epidural analgesia is safe for the control of pain. Fetal scan surveillance at third trimester, because the woman is at risk of small for gestational age or IUGR fetus. So after the pregnancy, when the delivery and the postpartum period comes, the indication, timing, and the mode of delivery should be obstetric indication. There is no clear-cut indication for cesarean section. Vaginal delivery is safe. Yes, planned cesarean section for severe neurological problem can be planned with a discussion with the neurologist, patient, and the obstetrician. During labor, the patient is going into labor, the periodic emptying of the bladder is recommended. Indwelling urinary catheter should be placed if the patient is having epidural analgesia, which is routinely is not recommended for all the women. Assisted vaginal delivery may require due to maternal exhaustion, and it is indicated. Breastfeeding should be encouraged to all the women unless the woman is using disease-modifying therapies, which are not safe for during breastfeeding. The vigilance for disease flare-up soon after the postpartum till 3 to 4 months of the period. The woman should be counseled for the effective contraception to avoid unintended pregnancies. And most of the contraception methods are safe. And we have to encourage the woman for the mobility, disability, and medication while choosing the options. Some of the, almost all the contraceptives are safe, but if the woman is using some disease modifying therapies, we should discuss with the neurologist about the use of the contraceptions and indications and safety of the use of contraception for the mother who is using DMT's treatment. So overall, it is a very short and brief presentation just to build a confidence for the obstetrician and reassurance for the woman. The conclusion of the multiple sclerosis and pregnancy is the pre-pregnancy counseling and the careful planning will allow the woman to have the favorable pregnancy outcome. We have to reassure that overall pregnancy is not harmful. It may even be beneficial because it reduces the flares and it reduces the relapses during the immunosuppressive, special hormonal state of the pregnancy. The pregnancy outcome is not significantly different from that of the general population in this cohort group. Precaution may be required with a woman with advanced multiple sclerosis, yes. The breastfeeding should be encouraged in all postpartum period. The disease-modifying therapy need to be commenced at the event of the postpartum relapse. So this is the conclusion. I will end my presentation to avoid spoiling your weekend. These are the references. Thank you very much for your time and attention.
Thank you so much, Dr. Aska. This was quite an informative lecture. Thank you very much. Now the floor is open for question and answers. Thank you all for the panelists and Tawfiq Ali for allowing us to give an excellent presentation by my panelists. So coming to the questions, The first question will be for Dr. Mona Khalfan. Dr. Lubna has asked about throw some light on echogenic foci in fetal heart, its significance as a solitary finding. This is one of the commonest thing which we come across, and people are really confused about the relevance of echogenic foci. Dr. Mona?
Yes, thank you for the doctor who's asking. And thank you for Dr. Manjula to read it. Echogenic foci, I think with the advance in our machine, it becomes frequently seen and diagnosed. When you see it and you are expert in ultrasound, just you need to see if there is any other soft marker being isolated, carry no significant, except you need to do detailed fetal echo and look for any other soft marker. So if I do detailed fetal echo, nothing, soft marker, nothing except this isolated echogenic foci, it carry no significant. But if this patient is 35 or more, minimum, I will advise her to do NIPT, non-invasive perinatal testing. But other than that, and we need to, no need to scare really the patient coming thinking there is anomalous heart. It is not a heart anomaly, as you know, whether it disappear or doesn't disappear, it carry no significant per se. I hope I answer your question. So do detailed anomaly, detailed fetal echo, nothing, assess her risk of aneuploidy. And now, if she can afford NIPT, I advise them, do it. So we will relax.
Thank you, Dr. Mona. There was one question by Dr. Faiz that was on four-chamber view. If you find any anomalies, whether we should refer the patient to a fetal medicine specialist or to the fetal cardiologist.
I had already answered this by writing, but just I will mention it quickly. Depend on what you have. If you have fetal cardiologists and your fetal FMF people, they are not expert in detailed fetal echo, you go with them. Okay? If some of the fetal cardiologists, they don't know how to scan by themselves, they need you to show them the image, and then they will comment on it. So sometimes they are combined or conjoined clinic. So it depends on the experience. If I am fetal medicine and I cannot do detailed fetal echo, okay, it's better to go to pediatric cardiologist. But if I can do it, it can be done by fetal medicine. So it depends on the facility where you are sending.
Thank you, Doctor. The question by Dr. Sangeeta Chabria. Any recommendation for antibiotics dose adjustment for obese patients? Yes. For obesity, more than 120 kilogram patients, we recommend cefazolin, not me. The professional bodies, ACOG and NICE, they have recommended 3 grams of cefazolin to be given. And if the weight is less than 90, the studies are not very suggestive that we have to reduce the dose to 1 gram. Still, evidence is needed in that group. And the next question for for myself, it was by Dr. Faiz, whether we need to give extra antibiotic dosage in diabetics and gestational diabetic patients going for LSCS. I tried to find some evidence on this in all guidelines and in WHO as well. So far, I didn't get any answer for this. So we will have to wait for more evidence on this. Thank you. And the question will be next for Dr. Naila. Somebody wanted to know when the pap smear has to be done, in which phase of the reproductive phase or cycle. Probably they need to reframe it. It is probably they want to know which phase of the menstrual cycle they want to do a pap smear.
Yeah, actually pap smear can be done at any phase, but you have to mention when you are sending the pap smear report that it is which phase of the reproductive cycle. Like if you are doing it, which phase of the LMP you have to mention, and you have to mention patient is pregnant or patient is postpartum or patient is postmenopausal. So only thing is that you can do pap smear anytime, only that when the patient is bleeding, you should not do it. When the patient is having a lot of infection, you should not do it. But if otherwise, you can do pap smear anytime, and then you can mention that when you're doing the pap smear so that the cytologist can know that, okay, this is the condition of the patient and how they have to interpret the smear.
Yeah, thank you, Dr. Naila. There is another question for you. It is related to the ASCUS. Dr. Tahira is asking, my question is related to understanding related to HR-HPV and abnormal PAP, ASCUS persistent at 1 year. Should we wait till 24 months total or treat based on the age at 12 months itself?
1 minute. ASCUS says what she have asked?
It is related to HR-HPV and abnormal PAP, ASCUS persistent at 1 year. Should we wait till 24 months total or treat based on the age at 12 months itself?
Actually, if ASCUS is with ASCUS HR-HPV is positive, then you have to go for colposcopy. If high-risk HPV is positive, then you have to go for colposcopy. But if it is ASCUS says, cytology is negative, then you can wait for 12 months. Even if HR-HPV is positive, then you can wait for 12 months and then you do for next year again co-testing. If the co-testing again is negative, like if cytology is negative, then you can, and the HR-HPV is still positive, you can again wait for 1 more year. And if for 24 months continuously HR-HPV is positive, then you should go for a colposcopy. Like twice you can give the option for 1 year. But if both are positive, then you have to go for a colposcopy at the same time.
Yeah, thank you, Dr. Naila. There's one more question for you, asked by Dr. Mirvat. Her question is about the time of pap smear, doing the pap smear in the postpartum period. Like if the lady did it at 2 months postpartum and the HPV was negative and pap smear showed ASCUS. So what should be the right management, whether to repeat cytology after 3 to 6 months or do colposcopy? This is in the postpartum period.
Actually, HPV, if HPV is negative and patient is having ASCUS, then the recommendation is that you can wait for 3 years co-testing. If after 3 years, you can go for a co-testing, and then if both are negative, then you can send them for a routine recall, because ASCUS can be negative after 3 years. So you can safely, if HR-HPV is negative, then you can safely ask the patient to wait for another 3 years and then repeat co-testing after 3 years.
Thank you. There was a question for myself. Patient with GBS getting penicillin, going for cesarean section, needs to give any other antibiotic as prophylaxis? Yes, we have to give cefazolin because penicillin is a weaker antibiotic which doesn't cover most of the bacteria which we need to cover, like staphylococcus and all. So penicillin is mainly against GBS, the crystalline penicillin what we give. So it's ideal to give cefazolin if we are taking the patient for cesarean section. I think we have finished almost all the questions. Many are answered on in the box itself. Dr. Mona, you have anything to speak?
No, just I would like to thank all the participants. We appreciate that you tolerate us for more than 2.5 hours. I hope it was beneficial. And if there is any comment, we are ready also to accept. Please put it in your question and answer. If there is any comment you think we can improve in the future, we would like to thank Phytobiotic Manager and all the team who help us for this presentation.
Thank you very much. So we'll conclude the session with this. So see you again soon, inshallah.
Thank you. Thank you, Miss. Thank you, Phytobiotics. Thank you, all of you.
Thank you.
Bye-bye. Have a good weekend.